Hello, everyone. Welcome back to the Integrative Health Podcast with Dr. Jen. Today, we're going to be talking about bioregulators and peptides, which I love. And we're going to be talking to Dr. Suzanne Ferree. She is the senior physician at Vine Medical Associates in Atlanta, Georgia. She's a double board certified physician in family medicine and anti-aging and regenerative medicine. Dr. Ferree is an award-winning teacher of medical students and residents and has been on the faculty of Emory University, A4M, IPS, ACAM, and SSRP. She has been a featured guest on several podcasts, including SuperHumanRadio, HealthMatters, and YouniqueMedical. Dr. Ferree uses bioidentical hormones, peptide therapy, neural therapy, and regenerative medicine to treat patients with endocrine, mitochondrial, infectious, autoimmune, and neurodegenerative diseases. Her thriving practice treats executives and athletes from all around the world, as well as patients with chronic or unusual diseases. Her new book, CounterClockwise, comes out March 4th, 2024. So it's out. And in her spare time, she lifts weights, salsa dances, studies cellular medicine, Christianity, and plays with her dog, Natasha. Welcome.
Thank you so much, Dr. Jen. I appreciate you having me on the show.
Yes, of course. So tell us a little bit about your background and how you started using bioidentical hormones and peptide therapy in your practice.
So it started really with patients. They were the driver for, I'm sure a lot of people have that story. A lot of providers have that story where patients were unwell and I was hoping to get them better. And so I was researching what I could do. And actually a patient came to me and said, "Hey, will you fill my bioidentical hormone prescription?" And I said, "I don't know what that is, but sure." And so I filled it. The compounding pharmacist said to me, "Hey, it doesn't look like you know what you're doing. So can I send you to a conference?" And they did. The compounding pharmacist sent me to a conference. It was just a local, it was called Get Out of Line. And it just talked about how there's so much more out there that isn't being taught in medical school and isn't being talked about at the conferences that we typically attend. But there's tons of research. This is an evidence-based practice of medicine that's just not being promoted out there because it's not supported by the pharmaceutical industry. So at least that's my opinion. And so it's been great to learn other things that are out there and available. Of course, it started with bioidentical hormones, and then as patients got better with bioidenticals, some of them stayed not very well, and so we were unable to treat those patients, and so they didn't get better with treating their hormones, and so we moved on to what's the next thing. So what's the next thing? And that's what these integrative providers, Dr. Jen does, I'm sure as well, just look for what's the next thing that might help these patients to get better, because all of us are just trying to figure out things we can add to our toolbox, because everyone responds a little bit differently to every therapy that we have.
Yes, absolutely. And that's our goal. And that's why we went into medical school to help patients. I remember the first time that I went to it was like 2 different times I went to conferences with a compounding pharmacist. So similar to you, they were like, "Want to come along with me?" And Dr. Tara Scott, she was lecturing. It was in Toronto. I mean, this was like 7 years ago, 8 years ago. And I remember I was so mad. I was sitting with the compounding pharmacist who was a friend too. And I was like, "What? Like, why didn't we learn this during medical school?" I'm like, "This makes me so mad. Like, why?"
Yes.
I like the whole time it was so funny. He was just laughing at me. And it just opens your eyes to the grooming that takes place in medical school, which is like, ew. I mean, it sounds gross, but I mean, I felt like I was groomed by pharmaceutical companies in medical school, and I wasn't looking for the root cause. And when we go into medical school, we're so eager to help people. And we think that we're going into it more treating the body as a whole. When I went to DO school, that's what I thought. But it all is find the symptom, pair it with the drug. But then we have people like us that come out of it and we're very excited and vocal about what we're unlearning, right?
That's really true. I remember I probably saw 15 drug reps a day. So if you imagine, let's just conservatively say I spent 5 minutes with each rep. I mean, that's 2 hours out of my day that I'm spending more than I'm spending with my with those people. And that's time I could have been seeing patients. I could have been studying. So I finally realized that all they were doing was making me a salesman for them, an unpaid salesman for them. And that's just not what I wanted to be anymore. And that happened around the same time as this patient came to me with the information about her bioidentical hormones, and then everything rolled into another. Most recently, our practice has been really busy doing neural therapy. If you're not familiar with it, it's such a great treatment that's been really helping so many people. So it's not a panacea either. There's things that we can do, that patients respond to. Some patients respond to neural therapy, some patients respond to others. We can actually use some of the peptides in a neural therapy manner. So it's kind of fun. It's just another thing we've added to our toolbox. It's been really helpful.
Yeah. So what exactly are you doing with this neural therapy? Is this like for peripheral neuropathy? Is that what you're talking about?
We can certainly treat that. That's one of the things we treat. It's using procaine, which was the original derivative of cocaine back in the day when they created, we used to use cocaine for anesthesia. And then they realized that people were becoming addicted to cocaine, including providers. If you haven't ever seen the movie The Nick, it's awesome. But anyway, the procaine was the first derivative of cocaine that doesn't have the addictive side effects that cocaine does. And so the cool thing about it is it increases blood flow to the area where it's injected. So you're one of the things that happens a lot of times with these chronic conditions, tendinitis or neuropathy, is a decrease in blood flow to the area. And so if we can improve that or restore that, it can be very effective at treating things. We minimize the effect of things like scars. So if you have a surgical scar, a lot of women with that phalansteal, that low C-section scar, they will have, or hysterectomy scar, they will have a lot of problems. And if we just treat that scar with this neural therapy, we can find that they can restore blood flow to the area that has been lost for years. And they end up with improvement in a lot of symptoms, both pain symptoms, but also some urinary bladder symptoms, et cetera. And some sexual health symptoms we can get improvement with by using specific points of treatment for those patients. So it's been really interesting. We've been able to reverse atrial fibrillation in the office. So in the moment while the patient's having atrial fibrillation, we can reverse it. I've certainly had patients that didn't respond, but that was pretty cool when we were able to get them to respond to that. We've had migraines go away. We've treated patients with acute sinusitis. We've treated a lot of PTSD, and then just chronic sort of diffuse joint pains. We can treat those patients with procaine and they get really better. So it's been really exciting to watch what can happen using such a simple tool that's been around for a century. But no one talks about it. It's got very little large trials because it's procaine. It's an old drug that's been replaced by better drugs that don't do the same thing that procaine does. Procaine reestablishes the ability of the nerve to conduct its signal. So that's kind of exciting if we're reestablishing nerve conduction signals. If we can turn down the sympathetic response and turn up that parasympathetic, the sympathetic is that fight or flight response, and the parasympathetic is the rest and relax response. And if we can turn down that sympathetic or fight or flight response, people get improvement in all kinds of things like heart disease, lung and liver, kidney and brain. All of those are driven often by a sympathetic dominant state. So if you are a person who follows your heart rate variability, you can tell if you are sympathetic dominant or not. And most of us, since the pandemic, if not before, are pretty sympathetic dominant.
Yeah, my heart rate variability is garbage. I mean, it's like 25, like sometimes it's bad. I've been trying to do little things. I thought cold plunging helped for a little bit. I know I was seeing higher numbers. I just can't budget. I'm blaming it on my emergency medicine residency and some of the really bad stuff I saw. I know it's just trauma, and I'll work on me eventually, right?
I think that's a really, really good point. We underestimate as providers the PTSD is maybe an excessive, but probably not an excessive moniker to put on what we went through in medical school. I mean, I remember the surgeons, I was a surgery resident for a year, working 120 hours a week in the hospital, 36 hours on and 12 off. And I remember in the middle of that shift, a cardiothoracic surgeon throwing instruments at me because I was falling asleep. So, you just, I think we underestimate the trauma that we experienced as providers and the healing that we ourselves need to recover from that.
Yeah. Yeah, it's crazy. I know that's why, and I know I probably need to, figure that out. But yeah, my heart rate variability is it's pretty rough. So the neurotherapy, yeah, it's really cool. So you're injecting, are you using ultrasound and you're like breaking up fascial planes and letting those nerves reconnect kind of?
We don't use ultrasound
Yeah.
for most of the time. We just, the landmarks are very clear for most of the things we do. So there's not a need to use ultrasound, and we've done thousands of them. So they are, and they're very close to the skin surface to be able to treat. There's very little that you have to do that is, that would require an ultrasound. I know a lot of people do use ultrasound for that. We're using 30 gauge, which are tiny, itty bitty little needles. And we're using just Procaine. There's nothing else that we're introducing. So I feel very safe most of the time doing these treatments. We don't have a lot of patients who are morbidly obese, which certainly would blur some of the good landmarks that we have. I do struggle a little bit with some of our athletes because they're very muscular, and that can sometimes interfere, but I just am not going to do it if I don't feel confident with my landmarks.
Yeah. Wow, that's awesome. Well, let's talk about kind of a similar subject, because we're talking about, no one cares about Procaine because you can't really make money off of it because it's generic. Let's discuss this new FDA ban on compounding pharmacies and peptides and your thoughts on that.
Well, originally the peptides themselves were not supposed to be compounded. They had most of them are owned by several different pharmaceutical companies, and so, or at least by research labs. And so the compounding pharmacies really weren't supposed to be compounding them anyway. They're really only supposed to compound things that are existing, that are unavailable in whatever form. So for example, if you have an allergy to the dye that's used in the pharmaceutical version, you can get the veggie dye-free capsules, and then they can compound that for you. It's really just supposed to be per an individual patient for their benefit in that situation. So the coming out with a list of things they aren't allowed to compound really has to do with, there's some of this is conjecture. So it's not based on any serious adverse events. The only adverse events that are reported with these compounded medications, these compounded peptides, are local skin reaction from a direct injection, which is super common with anything that you inject. A lot of people will respond, even if it's not to the peptide itself, you'll respond to any injection with a reaction. And so that's the only reaction that was seen by, or that was reported. There was no serious adverse events. So the only reason why the FDA would want to do that is if the pharmaceutical companies were wanting to come up with their own version. And so that's what I think is what we're going to see down the pipe. We know that the GLP-1s are owned by the big pharmaceutical companies. And the reason why the compounders are able to make them right now is because they are unavailable through the regular routes. The pharmaceutical companies have been unable to keep up with the demand. Once they're able to meet the demand, that will change. They will no longer be able to compound them just for patent infringement, that sort of thing. What we're going to start to see is these peptides that are natural, for example, thymosin alpha-1, they're not allowed to patent a natural product. So the pharmaceutical companies. And so it's because thymosin alpha-1 is a natural product, they're going to have to modify it slightly in order to get the patent on the product. So that's, I think, what we're going to start to see is that the pharmaceutical companies will come out with these same things that are slightly modified in order to get a patent on them. Also, the ones that are in existence already that are slightly modified from the original version, we'll see that those will get the pharmaceutical companies will begin to pick them up. So I think because of the popularity, this has been a hugely popular treatment modality and patients have done really well with them. I think the pharmaceutical companies are looking at what is going on and what is happening and why are we using this. And so I think that's why they're getting so much attention now. And I think that's why the FDA has put the kibosh on compounding pharmacies making them. Keep in mind, they have not put a ban on providers prescribing or giving them to patients. But be careful out there. Most of your providers, a regular primary care isn't going to know what the neurologist, gynecologist isn't going to know what these peptides are. So when you go and report to your gynecologist or neurologist what it is that your integrative provider is giving you, they may not know what we're talking about. And I've had several friends get reported to the medical board because they didn't know what was happening. And instead of calling the provider and saying, hey, what are you giving this patient? I'm so curious. They just go and report to the medical board, which I think is a travesty because we all could learn more if they were jumping in a different way.
Yes. Yes. And it's really a disservice to the patient and to our health, like into the patient's health. Right. And it's so frustrating because I see this as a reactive thing, doctors that act like know-it-alls. If they see something or hear something that a patient's doing and it's working and they don't know it, then they report, or it hurts their ego. Where really they could just not be burnt out and they can learn about modalities that will actually work. Maybe like you did, take less drug reps during the day, take less free lunches. They should fast anyway. But anyway, it's a really long list of peptides. I remember when it came out, I just didn't believe it. I don't know. I felt like, really, is this happening? Because I think like 4 years ago or something, there were hints that this was going to happen. And I was like, oh, should I really start using peptides in my practice? I don't want them to be taken away once I'm using them. So when this happened and, I've been having such good success in my practice, I was like, oh, this is so sad. But my compounding pharmacist is like, just wait. And then talking to some of the peptide leaders, in the US, and they're saying it's going to be okay. They're going to work through this. This is a lot of like just weird lawyer stuff that needs to happen. But yeah, so I'm looking at the list right now and it's like a list of like 15 really good peptides that have moved the needle on patients' health. So, we can still talk about them though. But there is that weirdness with the new rules. They're listing their 503 category 2 list is what it's technically called. So, but there's still a lot of good things that we can use. And let's talk about some of those. We still have oral peptides of different forms. So, some of the oral forms were not on that list. And sometimes you can get them places because they're manufactured outside of the US and then they're sold as supplements. And there are some good companies that are reputable. We know they're good. There's also bioregulators. So there's still a lot of things that, they're not going to stop us from having people be healthy and, get into homeostasis, which is what these peptides do.
And I think the cool thing is this has given us the opportunity to move forward and begin to look at what else is out there. We've had so many things for a while that's like, and we can sort of rest on our laurels that we have all these great peptides that work amazing. But what's cool is there's this whole category of new peptides out there that we didn't know or that we hadn't researched, or that were just sort of put on a bench because, wow, we already have something that works well for that. So what it's forced us to do is become scientists again, which is great. And we're learning about and creating and producing and studying all these new peptides. So there will be several new ones that are available. And this is really exciting because we'll be able to use a whole new cadre of peptides. Just means I have to beef up my cerebral license so I can memorize them.
Yes, right. Well, you can still get it. Yeah.
Mhm.
Let's talk a little bit about bioregulators and how they're different from peptides.
So bioregulators are just 4 or less amino acids. So, a peptide is a string of amino acids that's up to 50 amino acids long, depends on who you listen to. The FDA, I think it's 43 amino acids long. So if you think of a chicken breast, the chicken breast contains protein. Those are 150 or more amino acids long. So we're talking about fragments of protein, and these 50 or less amino acids. And now if we talk about a bioregulator, it's 4 or less amino acids. Most of them are available orally, which is kind of cool because you don't have to inject them. Most of them are available, and most of them are available through capsule form, which is great. And then what they do is enter through the cell, enter through the nucleus, and change the way that genes are transcribed. And so they have a upregulation or downregulation of various genes depending on which peptide you're looking at. So that's kind of cool. There's a lot of them that are available. Some are involved in cartilage and heart and brain and lung and kidney. And they are coming from a natural source, from bovine usually source. So I think there is a company that's making them porcine because there are a few people that are concerned about the bovine source with prion disease,
Mm-hmm.
that mad cow disease.
And then there's a brand or a couple out that are synthetic also of the
Exactly.
bioregulators. So there's a lot of different options out there. Now, they've been studied, certain bioregulators, for longevity, and then Bill Lawrence is doing this study. If you want to talk about that at all, I
Sure.
like want to be signed up for it.
We just lost our big research guy that was out. He just died a few weeks ago. It was very sad. I had the blessing to meet him in London last fall, and he was with his lovely wife Svetlana.
Mm.
And but he's done most of the research in bioregulator peptides, particularly where that applies to longevity. And then most of his research was done with epitalon and the thymus gland peptide, bioregulator peptide. And so what they found is if they were giving these pineal gland peptide and the thymus gland peptide to several different studies. One was with every single person who worked for the gas company. It was called Gazprom in Russia. They gave them for 3 years straight. They had them take them every day for 3 years. And then they just 15 years later called them up to see if they were still alive. And the curious thing was the people who had been taking them, probably 50% higher rate of being still alive, even though they only took them for 3 years.
Mm.
That we know that when they called them later to see if they were still alive, about half of them, of the ones who had versus the ones who had not taken the bioregulators, had died. So that was pretty cool. So we know that there's some epigenetic transformation, meaning changing the way the genes are transcribed and changing you to a more youthful state. So these patients were living longer. They were less likely to get cancer, less likely to die of heart attacks, less likely to have pancreatitis, and that's or diabetes, and that's all related to having used these peptides. So Bill Lawrence is the PhD here in the United States who has been working with the Institute of Gerontology in St. Petersburg. And he is now doing the same exact study that was done over in Russia on American patients. And they're doing some cool research because they're looking at their telomere length and their immune age and comparing that in a 3-year study. They're doing a once a year telomere length and immune age to see if these patients, how they're responding to the bioregulators. They're actually, so far, the biggest negative for non-response is stress, which we've known this for years and years. And so managing your stress is really critical. Patients who did not have significant stressors actually had a better outcome. And this is in patients who've already completed the study, which is ongoing. So that's kind of cool to see that they had such a great response with just 2 peptides.
Right. Yeah, stress. So important. And I mean, most of my patients are women because, they're going through perimenopause, they have the stress, and it affects our health, and then they don't feel good. Their gut health, a mess and all of that. So really focusing on that. We're always going to have stressors, but our bodies are really resilient. So it's increasing that resilience and, turning negative things into positive, or just always think that, God is providing the greater good, that really helps. And it just can really hurt your health. And I see this again and again in my women patients. I'll use a silly example. I have 4 kids. My 4-year-old Emory, we're making a smoothie yesterday. He's on the chair helping me. He doesn't put the lid on. Smoothie explodes like all over my kitchen. And, it's in the morning. We're trying to get ready. And I just take deep breaths. I'm like, Emory, can you go to your room and get something? Just so I could just like have a second, reset, and he comes back and I'm like, okay, help me clean up. You just got to realize that, that's happening for a reason. It's okay. My counters needed cleaned anyway, right? We need to really switch the negative experiences we have to see, this is molding us for something greater. It's making us stronger. It's making us more resilient. Breathing, prayer, with meditation on verses, that has helped a lot. And I think you can tell if you're stressed or not. Like, how do you fly off the handle? Do you fly off the handle easily? Are you like a road rage driver, or are you just like a deep breath and you're not flipping people off? Right. I mean, we really have to just look back at our stress. And that's so interesting that even with the bioregulators, your telomeres should be lengthening, but they're not as much. You're not getting as amazing results. Can you explain to everyone, like, what are telomeres and like why does it matter if they're short or long, and what does it mean when they're shortening?
Sure. This is the tail end of your DNA. So your DNA comes in a little helical strand, and at the tail end of that DNA, it has sort of it's just a tail of non-transcribed pieces. And so at this piece at the end, every time the DNA is replicated, so when your cells divide, you replicate that DNA for each cell. And so every time you replicate, you lose a little bit of that telomere length. So as you're growing and dividing, you are losing a little bit of telomere length. That telomere length has been directly linked with longevity. And so longer telomeres are related to longer life. The question that's still sort of in debate right now in the scientific community is, if we can lengthen your telomeres, do we actually see longevity improve? Do we actually see, and that's a sort of difficult question to answer scientifically, but that's what they're working on right now. We know that a long telomere is associated with longer life, but does lengthening a short telomere equal longer life? And the jury is still out on that debate. We know that there's a correlation between them, but the causation is still debatable. And that's one of the things we're trying to figure out with this study with Dr. Lawrence.
Mm-hmm. Yeah, that's really cool. And it's great that they're doing it on Americans too. I tend to think we are a more unhealthy, stressed out group of people that live here. And it will be interesting. And we have different pollutants and stuff. So how many people are in this study?
Last I heard, I think he had 200 people in the study.
That's great. Yeah.
Mm-hmm.
And in Russia, they've been using these bioregulators, like, you were talking about the different studies, and also like in their military and their Navy. So a lot of research on bioregulators, and it's not a well-known word. Like you were saying, Dr. Ferree, if you go to your primary care doctor, conventional doctor, and start talking about bioregulators, they're not going to know what you're talking about. And they're probably going to think, they're going to be like, oh, you just heard that on a podcast and now you're asking me about it. But these are great things. Sometimes people will compare them to glandulars, because you're taking pieces of, an animal, like there's thyrogen for the thyroid gland, and it's going to go in there and activate different healing mechanisms in the thyroid. So that's how these bioregulators, there's kind of one for each body part, which is really interesting.
Yes. That's how I talk to patients about them, is think about your armor thyroid that comes from a usually porcine source. Mm-hmm. That's exactly how I think about these bioregulators. It's just a different glandular source. So I'm taking the adrenal, and I'm taking the muscle one, I think it's Gotorix, and then I'm taking the blood vessel, Vesigen, and I'm taking the Cartilax, that's the connective tissue. So that's the series that I'm on right now, of course, with a Epidolon and Thymogen.
Oh, that's great. And
Mhm.
for the cartilage one, we haven't mentioned that you compete in powerlifting.
Yes.
So let's talk about that a little bit. Have you noticed a difference taking that bioregulator in your
I
lifting?
think I haven't noticed a difference in my strength, but I've certainly noticed a difference in my recovery, in my ability to recover, which I think is critical because it means you can get back to the gym the next day.
Yes, that's really big. And a lot of people, if they have that delayed soreness from a big workout, or they don't feel good the next day, then they don't want to go back to the gym, and that's not good. So that's really helpful. So for the powerlifting, what got you into powerlifting, one, and tell us about these competitions and the adrenaline rush from that.
It's pretty fun. I didn't start out thinking I was going to compete, but it was during the pandemic when all the gyms closed. This was the only gym that was open. They had their back door open, so you could go in and they would let you work out in the dark, one person at a time. They would
Oh,
let you go in, and they had a trainer. You had to be with a trainer, so you had to pay for the training. But the trainers were really great at this gym, and my gym had closed.
yeah.
So I started going to this group, and I've been there about 5 years now. It was really, it's a great place to train. I moved from a sort of a beginner trainer to a more advanced coach. My coach has taken many people to nationals and placed in first place. So he has a really great reputation in the community. And so last February, I did my first competition and placed first, which was really fun.
Congrats.
Thank you. And then we competed again in a local competition in August. And that was really fun as well. It's interesting when I think you don't realize that as you're approaching competition, that it's another example of a way to trust the process. You have to trust the process and realize there's going to be ups and downs. It's not a straight line trajectory. When you're intentionally training, you're going to have days when you're not doing so great and days when you're doing amazing. And the overall path is going to be one that's positive. And how you show up on the day that you compete is important. One of the things that was tough for me is I needed to compete in the lower. I was just at the line of the weight class. So competing for powerlifting, just like a wrestling, you have to weigh in. And so you compete with other people that are your same weight.
Okay.
And that's a challenge, of course, because if you're petite and you weigh the same as I do, you're going to be more successful at powerlifting than I am. And I'm not tall, but I'm 5'5". So for a power lifter, I'm a little bit tall. So so I have to be stronger in order to compete at that level.
Yes.
Anyway, and then you have to change your diet in order to maintain your muscle mass and strength, but you also may need to shift your weight class. So that was a big lesson in diet. I had a dietitian that was working with me as well as my coach. And of course, you have to use a chiropractor, and I go to massage therapists. And so it was a whole team of people that were working with me on getting me to these competitions. So it was really fun. And of course, competing it was raw, so there was no drugs were allowed, and so and then no I could use knee sleeves. That was the only assistive device that I could use.
Wow, interesting. This is so interesting. What about age brackets? Were there age
Yes.
brackets? Oh,
Yes.
good.
Mm-hmm.
How like what's the big range? Is it small, short? How many?
Usually about 5 years, so
Okay.
it's usually like 51 to 55 is
Okay.
where I compete. Mm-hmm.
Okay. That's really cool. So yeah, with the mechanism, it's funny. I was just at the gym with my husband, and he's like, it's so much harder for taller people to lift. And I'm like, yes, I know, but like, stop making excuses.
Yes. Yes.
And then you're doing what, chest press or bench? I mean, sorry, you're benching, you're doing deadlift, and then you're doing squat.
Yes.
Are those the three? See, deadlift, like I might just have to get someone to like watch my form because if I try to overdo it on the deadlift, my back hurts. So
Yes.
it might be a form thing with me.
That
And
shouldn't hurt.
yeah. And that's one that people tend to get injured on the most, right? Is the deadlift, because they're trying to show people how much they could deadlift and then they get hurt, right?
Yes, it's really about form, and so this past August was the last time I competed, and so we've dropped down the weight that I use and are working really strongly on form and keeping your body up. Our tendency throughout our entire day is to sit over our computers or over our phones, hunched like this, and if you're not sitting up like this, you're not going to be able to do. So we did a ton of work. Good mornings and belt squats with a chest harness and all the things we could do to work on keeping upright as you're doing all three lifts, so that you're in the optimal position to get the most weight up. And all you have to do in powerlifting is one squat, one bench, one deadlift. That's it. And you're trying to see how much you can lift at one time, as opposed to a lot of other competitions. The Olympic lifting is people ask that question a lot of time. Olympic lifting is the clean and jerk, which is overhead, and then the snatch also overhead. And powerlifters don't have enough shoulder flexibility for that.
Yeah, it's a whole different world. That's really
It
interesting.
is.
Now, are you allowed to be, well, obviously you do take bioregulators, so they're allowed with this non-drug. What about like certain peptides?
So all the peptides are none of the peptides are WADA approved. So if you are a competitive athlete, particularly at the national or international level, you are not allowed to take any peptides.
Okay, but bioregulators are allowed currently.
The WADA direction says no peptides.
Interesting. Okay, yeah. And I know it, like with fitness competitions, there's you can take medications and testosterone and then some not, and it depends on the organization, right? The regulations anyway.
Absolutely. And there are powerlifting organizations that do allow you to take testosterone, for example. For a menopausal woman, taking testosterone at a physiologic dose, I'm not talking about super physiologic doses, but at a physiologic dose to help with your hot flashes and night sweats, I think that's equivalent to taking insulin for a diabetic.
Right.
It's a hormone that your body is depleted of. You should be able to take that to be able to function.
Right.
So that's a challenge for me to help move the needle on, but.
Yeah, absolutely. Especially, many women, not all, some maintain testosterone through menopause, but many don't. And they do need that, or they're going to lose really important muscle mass, which is really important as we age. So I love that you're, competing. I looked into it. I don't know. Maybe I don't think it's in the works for me. And this year, maybe next year, I'd have to hire a really good coach and I think perfect my form. I think that that's the main thing. Now, you have a book that is out. Can you talk
Yes.
about your book? I'm so excited to get my hands on it.
Thank you, Jen. I'm super excited. It's called CounterClockwise. The name was given to me by one of my patients. He's very sweet to help me get that. It is a book that's really focused on women. The dosing and the protocols are really designed for women, although it applies to men as well. The patient examples that are given are mostly women. So it's designed for you to be able to not have to read all the way through. You can pick the chapter that interests you the most and just read that chapter. Of course, it's patient cases from my own patients that we treat, of course, because I would tell you what I do with my patients. You probably do something different than what I do with patients. And so there is at the beginning a vignette, and then there is some science that's sort of high level science around the peptides. Then there's a deeper dive. And then I give you some stacks that are options. And all of this you could bring to your doctor and talk to them about so that they may be able to provide you, or you can find a provider who does peptide therapy. A4M has a list, IPS has a list, and SSRP has a list of providers who do peptide therapy regularly. I highly recommend that you find a provider that does regular peptide therapy on a lot of their patients so they actually know what they're doing. Finding someone who doesn't know what they're doing can be problematic, and they may harm you instead of helping you.
Mm-hmm. Yes, absolutely. So where can everyone find you and your book?
So you
Website?
can actually get the first chapter for free if you go to, it's the online version. You can go to vinemedical.com/counterclockwise. That gets you the first chapter for free. The entire book is available on Amazon and Barnes and Noble. And then then you can find me at Instagram at DRSFERREE, Dr. S. Ferree. And you can find me on Facebook at Dr. S. And vinemedical.com is the practice.
Yes, that's amazing. I will put all of that information in the show notes also. Thank you
you.
so much, Suzanne. Thank you so much for being here and sharing your knowledge. And yeah, do you post about your weightlifting like competitions on your Instagram?
They are, yes.
Okay. Okay. Awesome. Those will be fun videos to watch for everyone.
Thank you.
Thank you so much.